what I have been given. 15 minutes is what I have been given, but yes, my presentation is a little lengthy. I couldn't help it because there's so much happening in the arena of oropharyngeal cancers, but I'll try to finish on time so that we could discuss after the cases have been presented. So now coming to oropharyngeal cancers. Oh, God, okay, 1 minute. Yeah. So we know that the worldwide incidence is roughly around absolute numbers of around close to a lakh, to a million actually. And of this, about 0.5% of these cancers are about, of all cancers are about oropharyngeal cancer. In India, it is about 1.6% of all cancers. And this is from the recent Globocan. Now, setting the stage, it is important for us to understand the patterns of spread of this cancer. So if you look at this age-old table that most of us in radiation oncology at least refer to, you will see that if you look at the oropharyngeal subsites of base tongue tonsil, they are a very lymphatic rich site, and also therefore lies the fact that they have a tendency to metastasize to lymph nodes, so that even in the clinically negative neck, you may have a high incidence of positive lymph nodes. Now, what about the incidence of contralateral lymph node metastasis? Here also, if you look at the base of tongue, there is a very high chance of contralateral lymph node metastasis, not so for the tonsil if it fits certain criteria. Now, starting with the diagnostic evaluation, of course, it begins with a thorough thorough history taking, followed by clinical evaluation, which involves a thorough inspection and palpation of the oral cavity oropharynx and bilateral neck, followed by an examination under anesthesia whenever feasible, but at least a direct laryngoscopy for mapping of the disease, followed by a biopsy, and of course, imaging is mandatory today. Now, we need to know the role of certain investigations. I am not talking of the CECT and the MRI because I think the role of these conventional imaging modalities is well understood. We know that the MRI is a very useful tool in the oropharynx because it helps delineate the extent of the soft tissue disease and also the lymph node metastasis. Hence, I'm particularly discussing the role of the FDG PET-CT. Here, the role essentially lies in advanced disease where you have a heavy nodal burden, especially in the low neck, and in recurrent disease. Now, this is important simply because we should not go ahead doing an FDG PET-CT without discretion in our patients. What we need to understand that the PET-CT value lies in the fact that it has a high sensitivity and specificity, and especially a high negative predictive value, especially in the post-CTRT setup. Now, this FDG PET-CT values are high both for the primary as well as at the neck nodes. Now, if you come to the management per se for the oropharyngeal cancer, if you look at the practice guidelines in the pre-HBV and the pre-TORS era, non-operative management was usually the preferred approach. And of course, with advances and with the appearance and use of combined modality management and concurrent chemoradiotherapy in various other sites of the head and neck, it, it almost became a standard of care that we would combine systemic therapy and radiation therapy, and especially because of the advances made in radiation technology. All this was associated with improved survival, and preferably in this site, what was the standard of care was a lower use of surgery. So if we looked at the pre-TORS, pre-HPV era for early stage disease, it was single modality treatment, either radiotherapy alone, which was either external beam radiotherapy alone or external beam radiotherapy with a brachytherapy boost in suitable cases, or surgery alone. Now, addressing the neck was very important in this site because, as we've seen, there is a very high predilection for lymph node metastasis. So the efficiency of radiotherapy and or surgery in eradicating subclinical neck node disease was almost to the tune of 90%. Observation or partial neck treatment could be possibly suboptimal, especially in primary lesions of the base of tongue and soft palate. But for lateralized tonsillar lesions, you could possibly get away without treatment of the contralateral neck, and we've seen why. Now, addressing the neck, this is again for any of the radiation oncologists who are there in the audience, and this is essentially the paper by Julian Biao, which typically tells us about the nodal volumes that need to be included in the high risk and the low risk levels, depending upon the extent of disease and the extent of nodal disease. Now, ipsilateral irradiation is specifically mentioned in the oropharynx, especially in lateralized tonsillar cancers, which fit certain criteria. That is, they have to be T1, T2 lesions, N0 or N1 tumors with less than 1 centimeter extension to the soft palate and no involvement of the base tongue. So you can understand very well that with these criteria, you eliminate the need for contralateral lymph node irradiation. And so typically a lesion would be somewhere like this. You would have it lying in the tonsillar fossa with less than 1 centimeter extension into the soft palate, no involvement or less than 1 centimeter involvement of the base tongue. And these patients would be candidates for unilateral radiation only. And this has stood the test of time. There are several series that have reported the outcomes with unilateral irradiation, with outcomes as high as 90% control and in some cases even 100% control. And the regional failure rates with elective bilateral radiation in both this is what can be seen. Any neck failure, if you look at it, is very low, less than 5 to 7%. And this is irrespective of the HPV status of the patient. So if you look at this, just a minute, I'll just, I don't know, I just want to disable this annotations 1 minute. Okay, anyway, so the results of this have been confirmed even after the 1995 publication, and the results of ipsilateral radiotherapy for the same group of patients have actually been confirmed by the Princess Margaret group. And it still remains that in patients, despite the HPV status, unilateral irradiation of the neck is possible in early tonsillar cancers. Equally high locoregional control and survival irrespective of the HPV status, and the original principles of case selection for ipsilateral radiotherapy remain universally applicable even in the HPV era. And these are the local control rates, whether it is HPV positive or HPV negative. And this is the regional control rate, again irrespective of the HPV positive or the HPV negative status, irrespective and comparing unilateral to bilateral radiation, and so also the late toxicity. Now, if you come to the advanced stage, that is, you have advanced T or advanced nodal disease, of course, you have to institute combined modality management. And usually, again, in the pre-TORS, pre-HPV era, it was concurrent chemoradiotherapy or concurrent chemoradiotherapy with cetuximab in the cisplatinum ineligible or altered fractionation, or in some suitably selected patients, it would be surgery with adjuvant CTRT. Now, what we need to understand is that so far what we knew in the pre-TORS, pre-HPV era was single modality treatment for early stage disease. RT was usually preferred. Combined modality approach was reserved for advanced stage disease. Good local controls with acceptable toxicity were achieved. But what happened was that there was a revolution in the way radiotherapy could be done. What was done in the pre-HPV, pre-TORS era was usually conventional to 2.2 to 2.5 DRT, and open surgical approaches were the norm of the day. Things changed. What happened now was there was a change in the epidemiology. HPV-related cancers began to appear. Then you had recognition of the toxicity of CTRT, IMRT, which is a superior modality for delivery of radiotherapy, was available, and of course advent of minimally invasive surgery was the other thing that we saw. So what happened? We all are familiar with this paper from Chaturvedi, which shows that clearly in the West what was witnessed was there was a definite decrease in other head and neck cancers, but the oropharyngeal cancers began to rise, and even amongst the oropharyngeal cancers, it was the HPV related cancers that were becoming higher. And this was not only true in the Americas, started to see a similar trend even in Europe. And what happened was that you see the SEER database from 1992 to the early 2010s, you see that there was an increase, percent proportion of oropharyngeal cancers contributing to head and neck cancers definitely increased. The other realization was that there was a striking difference between these two groups of patients, especially in terms of the incidence, the risk factors associated, the sex ratio, age, performance status, anatomical site, histology, stage, and the treatment parameters were very different. And the basic thing was that HPV positive cancers seem to have a better outcome. Now, this is a table showing you the post hoc analysis on several of with this realization, what happened was that people realized we could perhaps look at different things, and hence what happened was that we did see that there was a difference based on the HPV status within these clinical trials, again showing that typically there was an improvement in the outcomes related to the HPV status, and this was statistically significant when compared with the HPV negative group. Now, one seminal trial deserves mention simply because this was the trial that gave us the recursive partitional analysis to be able to risk stratify patients into the low, intermediate, and high risk groups based on the HPV status as well as the smoking status. And 433 of the 721 patients who were eligible were you could do HPV status, of which it was determined in only about 74.6% of the patients, and in which about 64% patients showed tumor HPV DNA. Now, in these patients, typically what was seen was based on the HPV positivity or negativity. The HPV positive patients had superior outcomes when compared to the HPV negative patients, both in the risk of death as well as in the risk of relapse. Also, there was a definite correlation between HPV and tobacco use with increased risk of death and cancer relapse related to the additional pack years of tobacco smoking. And based on this, they arrived at 3 risk groups: low risk, intermediate risk, and high risk, based on the pack years of smoking and the HPV status, and of course the N and T status. Now, this was also reflected in the outcomes, the overall survival in these patients. And the secondary outcomes of the trials that I showed you again typically told us that this was an important predictor of prognosis, higher response rates, better survival, improved survival, and there were 3 different groups. So this led to a change in the staging system. So if you look at the 8th edition of the TNM, there is a definite difference in the staging system based on the HPV status. And for HPV positive patients, they have a lower stage. There is no N2C or N3. And this is what differentiates the 8th edition from the 7th edition. And this is what everybody could refer to. The next thing, of course, is newer surgical approaches. Of course, what we saw was that in surgery, there was an advent of minimally invasive transoral techniques. I don't need to go into details for this, and I will not be doing that for this essentially surgical crowd. And what we also understood from these surgical approaches was that they were oncologically safe with perhaps improved functional outcomes. Now, based on all this information that you had on this subset of oropharyngeal cancers, there was this decision that needed to be made. Do we need to alter treatment, or do we need to continue as it is? If we need to, then why? Because perhaps we could reduce the toxicity, and perhaps we could reduce toxicity further because we have better radiotherapy and surgical techniques available. Why no? Because we didn't want to do anything with the outcomes. But yes, how could we have possibly modified treatments? So the ways to do it would of course be replace chemotherapy with biologicals, reduce the radiotherapy dose, omit chemotherapy if possible, or reduce the chemotherapy, reduce the radiotherapy volumes, integrate surgery into the management. So these are a few trials which are famous for trying to replace cisplatinum with cetuximab, the RTOG 1016, the de-escalate HPV, and of course the TROG trial. Now I will just take you through the TROG trial. So this was another study that actually looked at randomizing low-risk HPV positive patients, stage 3 or stage 4, comparing RT 70 grade 35 fractions with cisplatinum or with cetuximab. The primary endpoint was of course symptom severity, like the de-escalate. What they saw was that between cisplatinum and cetuximab, actually there was no difference in these groups for the primary endpoint of the symptom severity. There was no difference. What they also saw that in the outcomes, there seemed to be a detriment for the group actually which was receiving cetuximab, and hence they concluded that there seemed to be no improvement in symptom burden or toxicity, and radiation and cisplatinum remained the standard of care. Now from here, what it tells us from the 3 randomized trials is that it does not support the replacement of cisplatinum with cetuximab in HPV positive cancers. The other way to modify therapy is, of course, you could do induction chemotherapy, look at the response, and then modify the dose of radiotherapy. There are several phase 2 and phase 3 trials that have been published, and the quarterback study is the only study that we have to look at. There is another way of doing this. This is the ECOG ACRIN, which actually showed us that it was possible to perhaps safely reduce the dose of radiotherapy post a favorable response to neoadjuvant chemotherapy. And this is the outcome. It possibly told us that even with lower dose radiotherapy, the outcomes were not compromised. This is the PFS and the overall survival in this trial. And this could possibly be something that we could explore in our patients. Can we reduce the dose or the treatment of chemotherapy? Again, these are the various trials that have been done, mostly phase 2 and phase 1. Then there is, of course, this thing of reducing the radiation dose, the RTOG, the NRG-HN002. This was a phase 2 randomized trial, 306 patients, which explored 2 dose fractions of radiotherapy, 63 IMRT with concurrent cisplatinum or accelerated radiotherapy. And what we did see was that there was no difference in these 2 groups, and the outcomes were quite acceptable despite doing something that was unconventional. And of course, this also justified the fact that we could possibly go on to a phase 3 study. But we wrote to the PI, and we thought that these were unconventional methods, and we firmly believe that we are still not ready for prime time use, and we need to wait for further more mature results. Now, increasing roll-off surgery, till date we could say that there was no randomized trial to study between surgery versus radiotherapy, but of course the main advantage of TORS was that immediate versus protracted treatment, accurate prognostic information would be available, and cytoreduction would enable reduction in the hypoxic volume of the tumor, sparing of the swallowing apparatus, and sparing the acute and troublesome late toxicities. Based on this, of course, we all know about the Orator 1 and the Orator 2. The Orator 1 was a randomized trial, randomized 68 patients looking at the final endpoint, primary endpoint of trying to see a reduction in the toxicity, the quality of life, which should have been a 10-point difference. But if you look at the study, you see that the difference between the 2 arms, though RT, which turned out to be superior, was not a 10-point difference, but it was still statistically significant if you look at the various domains of the MADADI. And of course, patients with the P16 positive tumors had markedly improved overall survival and progression-free survival compared with those who had P16 negative disease. And in conclusion, they said that the early swallowing results or quality of life was better with radiotherapy as compared to surgery. And if you look at the long-term results which were reported in January 2022, the difference became narrower, but there seemed to still be a difference. But you may not, if you are a purist, you may not call this still significant. Okay, so, but the trial actually, if you look at the numbers, only 68 could perhaps not have answered that question. Then we had the Orator 2, which was a phase 3 trial, which was again looking at transoral surgery over radiotherapy. We heard the early abstract. The trial had to close prematurely only after randomizing 61 patients, unfortunately because of two grade 5 toxicities in the torso and neck dissection arm. But again, in this study, what we saw was that the outcomes seem to be superior with the radiotherapy as compared to torso. But again, it's a little too early to take home any concrete message. Based on this, the only take home that I have is that the two options remain equally viable. Equivocal results can be attributed to the small sample size. Also, the surgical skills may be attributed to low volume centers, and of course, TORS we know is associated with a learning curve. Now, we have now understood that there is a better prognosis for HPV positive patients. They have a different biology. There's an increasing role of surgery, and possibly there could be a change also in the indications for adjuvant radiotherapy without compromising the outcomes and the quality of life. So you have these three trials in that space, and this is the ADEPT, the ECOG 3311, and PATHOS. I'll just quickly go through the ECOG 3311 just to drive home the point about the difference in the kind of adjuvant radiotherapy parameters that people have talked about. And here, if you look at it, this trial actually has divided patients into low risk, intermediate risk, and high risk. And the trial essentially tries to see whether there is a difference in the different doses of radiotherapy in the intermediate risk group, which is the close margins less than 3 millimeters, 2 to 4 lymph nodes positive, less than 1 millimeter of ENE, PNI, or LVE being present. And of course, the early results show that primary TOS and reduced postoperative radiotherapy results in outstanding oncologic outcomes and favorable functional outcomes in the intermediate risk HPV OPSC group. But all this brings us back to this very vital question, the burden of acute toxicity. Combination therapies have increased the toxicity burden. And if you look at the long-term morbidity, we look at swallowing dysfunction, pharyngeal strictures, xerostomia, and dental defects. I've been asked to talk about the importance of DARS structures. So we know about the DARS structures. Dysphagia is a distressing symptom that we see in patients post-CTRT, observed in almost about 50% of patients. 1/3 of dysphagic patients actually develop aspiration pneumonia, and mortality rates in different studies range from anywhere between 20 to 60%. So these are the various causes of dysphagia: age, because of the disease and the extent of disease, and of course, the treatment-related dysphagia. And it is important for us to identify these causes so that they can be addressed appropriately. These are the various criteria by which we assess the dysphagia, the clinician reported, which include the RTOG late toxicity grading, the NCI common toxicity criteria, and of course we have the MADADI as well as the PSSHN scores. Now, instrumental assessments actually are important because, as we see from other studies, that there is a definite need for instrumental assessments. This could be a simple 100 ml water swallow test, FEES, VFFS, or looking at the manometry. Now, what are the various aspects of the DARS structures that are affected? Practically all aspects of the swallowing mechanism are affected after radiotherapy. And we should remember that even after TORS, there is a sizable group of patients that may develop swallowing dysfunction, and that could be attributed not only to the surgery, but also for the need for adjuvant therapy post-surgery. So the pioneering work to establish the role of IMRT for protection of DARS structures was done by Afram Icebrook, and they clearly identified that the pharyngeal constrictors, the glottis and the supraglottic larynx were involved in the dysphagia aspiration related structure abnormalities seen post radiotherapy. And the various studies by Levendag, Feng, Kaglar, and of course especially from the Icebrook group, gave us the various dose constraints that we today know and identify for the protection of these structures. But it is most important for us to understand that the dose to the pharyngeal constrictors actually contribute maximally to preventing late swallowing disturbances. How can we manage? Prophylactic swallowing exercises, DARS optimized radiotherapy. This is the various swallowing therapy that can be advised and should be advised to patients at baseline, through treatment and post-treatment. In radiotherapy today, we also have contouring of dark structures, which enables us to identify the structures, also understand the doses that are received by these structures. So the various structures, how to contour them on our actual CT scans. These are the pictures of the same. And of course, we also have a randomized trial which looked at dose optimized IMRT versus standard IMRT. And it clearly showed us that this is a trial from Chris Nutting. And if you do all this, I'm not going into the details because for want of time, we do realize that it is possible for us to spare the dysphagia aspiration related structures. The doses can be reduced, and as a consequence of the reduction of the doses, what we do realize is that it is possible for us to improve swallowing related outcomes post DAS optimized radiotherapy, and this was the first randomized trial doing so. If you look at the difference, this is what it is. With the use of IMRT, there is a definite reduction in various dysphagia aspiration related events, and this is primarily because not only because of reduced doses to dysphagia aspiration structures, but various other sequelae of radiotherapy also. Another way, of course, of reducing the dose would be by the judicious use of brachytherapy as and when possible, because with this we could definitely reduce the dose to the constrictors. However, having said all this, I bring you back home, and what you need to realize here is the fact that a lot of what I've said may be related to HPV positive cancers, but a lot of it is also related to HPV negative cancers. And that is what we are dealing with in our country. And we do know that they are different. But if you look at HPV negative cancers, we always talk of treatment intensification and not de-intensification. And we do remember another thing from this large NCDB analysis, again, is that there is a difference in how different sites within the oropharynx also behave. And even there, especially in the HPV negative group, surgery or surgery followed by CTRT, again, there seems to be a statistically significant difference. And in India, we know that if you look at sites, it's base of tongue that is more common than tonsil or soft palate. So the reality is that survival outcomes for HPV negative oropharyngeal cancers have not improved, and it still remains low. The long-term quality of life of these patients is also poor, and we may have to do something more for our patients. What are the strategies available then? If we look at our HPV negative cancers, non-surgical, we have neoadjuvant chemotherapy, altered fractionation, dose escalation, escalating by addition of targeted therapy to the concurrent chemoradiotherapy, and surgical, of course, surgery here may then be used for intensification. So this is the recent meta-analysis published in 2020, and here, of course, if you look at the rank of treatment, we have talking about escalating therapy, especially if you talk about HPV negative cancers. Then, of course, we do have evidence, some amount of it, especially from our nemotuzumab study. And here we do realize that perhaps the HPV negative oropharyngeal cancers may be that group which may actually benefit from intensification by the addition of a targeted agent to the concurrent chemoradiotherapy. Or we could also escalate therapy with the addition of surgery. And these are a few trials that have actually shown that the insertion of surgery into this paradigm or the protocol may actually improve outcomes. This is the analysis recently published data from AIMS. And here again, you do see that there may be some importance of actually being able to do surgery as compared to doing only RT in patients with concurrent chemoradiotherapy. We are in the process of, we've actually initiated this trial at the Tata Memorial Hospital, where we are trying to look at doing primary surgery as a part of the treatment protocol in HPV negative oropharyngeal cancers. Another important thing is that we need to take care of the enhanced toxicity and poor quality of life. This could be by better surgical techniques, appropriate utilization of available imaging, integration and multimodality, especially image fusion during RT planning, use of modern radiotherapy techniques, judicious use of adaptive radiotherapy, timely institution of supportive care, especially nutrition, hydration, and prophylaxis. In conclusion, an increasing association of OPSCCs, especially arising from the palatine and lingual tonsils. This is the case in the West. Here we often see tumors that are HPV negative, but you have to understand that there is a definite association with smoking. HPV status confers independent survival benefit. Risk stratification should take into account stage T, N, and smoking status. And the current treatment should not be different from the standard treatment out of a protocol. Even in the HPV positive population, cetuximab cannot replace cisplatinum. Most of the data in the HPV positive population is still phase 2, cannot be extrapolated to the clinic. And in the Indian context, importantly, its relevance is questionable, especially due to small numbers confounded by smoking and or chewing tobacco with advanced disease. Oropharyngeal cancer in this context may need intensification, so we have to identify optimal combination therapies. And most importantly, quality of life and supportive care should be addressed even in these group of patients who are HPV negative. I thank you for your patient hearing, and I'm sorry for having overshot the time. Thank you very much.
After this wonderful talk, now we would like to move on to the case presentation. I would like to invite the examiners and moderators, Dr. Salwani Ghosh Laskar ma'am, the professor in radiation oncology department at Tata Memorial Hospital, Mumbai, ma'am. Then Dr. Ashok Das sir, professor, Department of Head and Neck Oncology at B. Barua Cancer Institute, Guwahati. Sir, are you there? Yes, sir. Then Dr. Vipin Arora, sir, Director Professor of ENT and Head and Neck Surgery at UCMS, University College Medical Sciences and GTB Hospital, University of Delhi.
Yeah, good evening.
Good evening, sir. Then Dr. Manish Meyer, Head and Neck Surgeon at John Hunter Hospital, Australia.
Hi.
Are you there, Dr. Manish?
Yeah.
I was. Now, I would like to invite Dr. Ankit Vishwani from RCC Trivandrum for case presentation on oropharyngeal malignancy. Dr. Ankit, are you there?
Yes, sir. Good morning, sir. Am I audible?
Yes, you are audible, Dr.
Okay.
Please go ahead.
Good morning, respected seniors. Sir, my screen is visible, sir.
Yeah, it's visible. It's visible, Ankit.
Okay, sir. Shall I start, sir?
Yeah, please.
Okay, good morning, respected teachers. I'll be starting my case presentation. Our patient was named Mariamma, 71-year-old female. She's a housewife, resident of Pathanamthitta, Kerala. Her chief complaints, she presented with chief complaints of dysphagia for 6 months, difficulty in speech for 2 months, increased salivation for 2 months, and halitosis for 1 month. Coming to history of presenting illness, first talking about dysphagia, it was insidious in onset. It was gradually progressive, but in last 2 months it rapidly progressed. It was associated with painful swallowings, more to solids than liquids. The difficulty in speech was insidious in onset, gradually progressive, and was associated with muffled voice. The patient also had complaints of increased salivation, which was insidious in onset, gradually progressive, and also patient had complaints of halitosis, which was also insidious in onset and gradually progressive.
Ankit, is it actually the increase in salivation, or it is drooling because of inability to swallow?
Yes, sir. Mainly she complained of collection of saliva in mouth due to pain and inability to swallow, sir. Not increased salivation, but more saliva in mouth because of that painful because of that odynophagia. And
so it is basically because of the inability to swallow.
Yes, sir. Yes,
so it's not increased production.
Okay. Yes, not increased production, sir.
Yeah. Please continue.
Yes. Now coming to negative history, she didn't give any history of ear pain, difficult breathing, or any bleeding from oral cavity. There was no history of any significant weight loss and no history of any neck swelling. Coming to past history, there is no history of surgery, no history of COVID. She is vaccinated 2 doses. There is no other significant medical disorders and no history of any drug allergy.
Okay, can I just interrupt you
Yes,
for
sir.
a minute? Yeah.
Sir.
Can you just go back to the negative history and can you just elaborate why all these negative histories are important for your case?
Sir, negative history?
Yeah.
Sir,
can you just elaborate?
Sir, ear pain can be due to referred pain from oral cavity, or since patient is having dysphagia. Their causes oropharyngeal lesions and oral cavity lesions can have referred pain to ear because of the glossopharyngeal nerve in the oropharyngeal lesions. Difficulty breathing can be due to a bulky oropharyngeal lesion, which may cause upper airway obstruction. Bleeding as a part of routine examination, routine history taking from ulcerative lesion, which could bleed, and significant weight loss in a malignant patient, in a patient with a suspected malignancy. We have to rule out significant weight loss that is more than 10% in last 6 months, and neck swelling for neck locoregional involvement, sir.
Can you just on your video, because we have not seen you? Okay.
Sir?
We are not. Yeah. Can you on your video? We are not.
Yes, sir. Yes, sir. I'll just
anyway, so
1 second, sir. Sir, is my video visible, sir?
It's dark. It's completely dark.
1 second, sir.
Yeah.
1 second. Is it visible, sir?
No, that's fine. Please go ahead.
Ankit, one more negative history of bone pain you can add, and I think the order of history taking. I think if you look at ear pain, bleeding, difficulty in breathing can be, and neck swelling, and then you talk about metastasis. So I think weight loss will be, neck swelling is very important. I think with some in the top.
Okay, sir. Yes, sir.
Can you elaborate the phase of ear pain? So the referred ear pain.
Sir, sorry, sir.
Can you elaborate the pathways of ear pain?
Sir, for oropharyngeal lesions, the referred pain can be due to glossopharyngeal nerve causing causing the tympanic with the Jacobson's nerve in the ear, tympanic branch, that is Jacobson in the ears.
So what kind of pain and where will be the pain in the ear?
Sir, mainly in the, sir, maybe in the middle ear, sir.
Yeah, so deep-seated pain in the middle ear.
Pain. Yes, sir.
Yeah. What about the ganglion? Which ganglion are, what are the efferent and the afferent nerve and the ganglion in this case?
So petrosal ganglion.
No.
So,
yes, I think it's superior and inferior jugular or glossopharyngeal ganglion.
Yes,
and the nerve is right. And the pharyngeal branch or the tonsillar branch of the glossopharyngeal nerve is the afferent nerve.
Yes, sir.
Do you know the pathways of other sites causing referred pain? Like, which are the other sites which can cause referred pain?
So pyriform sinus malignancy can cause a referred pain from 10th nerve, sir.
So there, what is the ganglion?
Yeah.
Not sure, sir.
So it's again superior and inferior vagal ganglion. And what kind of pain in the ear will you experience? Again, the site of the pain. Okay, just have a look at it. It might be important. Okay, go ahead.
Yeah. Also, Ankit, just a point, like how you are putting the negative history. So difficulty in breathing in oropharyngeal case is a very late presentation, you know.
Yes.
Oropharynx is a very spacious site. So to give a difficulty in breathing, it's really the disease increase in size and in a very advanced stage. So you could better put it in, you know, last kind of thing,
Yes,
last of the list. Okay, go ahead. A very small thing.
Okay, sir.
Yeah.
So shall I proceed, sir?
Yeah, please.
Yeah, go ahead.
Coming to past history, there is no history of any surgery, no history of COVID. Patient is vaccinated 2 doses. There is no other significant medical disorders and no history of any drug allergy. Coming to personal history, patient did not give any history of any habits or substance abuse. There is no history of any sharp tooth or dental extraction. The patient has normal bladder bowel habits. There is no history of any sleep disturbances except for occasional recent snoring. There is no history of multiple sexual partners, IV drug abuse, or blood transfusion. Coming to family history, there's no significant family history.
Can you elaborate any familial syndromes for head neck cancers?
Sir, Lee-Fermani Bloom syndrome, xeroderma pigmentosa,
Yeah.
Fanconi,
Yeah, do you know
ataxia telangiectasia.
Do you know the characteristics of each? Just go through it. I'm just
Yes,
telling
sir.
the question.
Sir.
Yeah, go ahead.
Coming to a summary on the basis of history, she's a 71-year-old female with no major comorps, no habits, with a history of dysphagia for 6 months with rapid progression in the last 2 months, and a recent onset muffled voice and pooling of saliva in the mouth. Not increased salivation, basically due to difficulty in swallowing, some collection of saliva or drooling in the mouth.
There is no significant weight loss, what I understand.
Yes, sir. No significant weight loss, no habits.
Okay, Ankit, what is the significance of weight loss? Like, why do you ask for it, and what is the significance you attach?
Sir, cancer, maybe because of cancer cachexia, metastasis. These two factors, sir.
So what do you derive out of it? What information do you derive out of it? If there is a significant weight loss?
Sir, two things. One is it could be a locoregional advanced disease. Other thing, the performance status of the patient can rapidly decline. Patient, if we are regarding performance status and locoregional extent of the disease, sir.
So in case you are planning any therapy for this patient,
Yes,
surgical or non-surgical, so weight loss, significant weight loss is an independent risk factor for adverse outcomes.
Yes, sir. Yes.
So you can summarize in one single line.
Yes, sir.
Another point, Ankit, you have mentioned that there is a history of dysphagia for 6 months, and
yes,
there is no weight loss kind of thing.
Yes.
Can you just explain? There is not at all any weight loss.
Sir, there is no weight loss would have been there, sir, but it was not significant, sir. But it's true, sir, that these both lines statements are contradictory, but it was not significant. That's what I wanted to tell.
Can you quantify what you want to mean by significant weight loss?
Some significant weight loss, usually what we have read is more than 10% in the last 6 months. Weight loss more than 10% in the last 6 months.
Okay. Based on your what is your diagnosis? I mean, you know the diagnosis, but based on your summary, what can be your differential diagnosis?
So based on this summary, since the patient is having difficulty swallowing, I would it could be a difficult it could be a oral cavity or oropharyngeal lesion, sir.
Okay.
Why do you say oral cavity?
Ma'am, we don't. Ma'am, if it's a bulky anterior tongue lesion, could be a bulky anterior tongue lesion. T4A tongue lesion will also have a similar presentations.
I don't think it's for the anterior tongue. It would be true for a posterior or a base of tongue, right?
Yes, ma'am.
Your hypersalivation as well as your change in voice or a hot potato speech would be true for a posterior tongue or a base of tongue, right?
Yes,
so when you say oral cavity, you have to be clear about why oral cavity. And it is not wrong if you say that this patient has a lesion that's located in the oropharynx, because the pointers are towards that, right?
Ma'am, both oral more likely oropharyngeal lesion, ma'am. but oral cavity, I said, because sometimes the bulk of the disease.
Yeah, but see, whatever you say is what the examiner is going to be led by, right?
Yes, ma'am.
You're going
Oropharyngeal.
yeah.
First GD is oropharyngeal only, ma'am.
Okay, fine.
Yeah, we would have been happy if we would have said that it could be a oropharynx or a supraglottic disease rather than,
oral cavity. Yeah.
oral cavity.
Or safer, even safer for exams, Ankit, I'll tell you, you can simply say that this is probably some lesion or tumor of upper aerodigestive tract.
Okay.
It's even more safer.
Yes.
Trick is to lead the examiner, don't be led.
Yeah.
Yes.
Please go ahead.
Yes. Coming to the examination part, first is general physical examination. She is on general physical examination. Patient is an elderly female, average built, moderately nourished, well oriented to time, place, and person. She's afebrile, a BMI of 24. Her vitals are stable. Performance status is ECOG performance status is 1. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Coming to local examination. Local examination of the oral cavity on inspection. Patient is having a bad oral hygiene. There is severe ankyloglossia, no trismus, no features of oral submucosal fibrosis. And there is a ulcer-indurated lesion with the irregular surface and no discharge or bleed. Its edges are everted. The size of the lesion is 3.5 centimeter. The other dimension I could not measure on inspection because posterior limit of the lesion was not seen. It is a 3.5 into some X centimeter lesion in the left side dorsum of tongue. It is medially, it is crossing midline. The posterior border is not visible. Laterally, it is reaching till lateral border of the tongue. And anteriorly, it is 5 centimeter from the tip of the tongue. Coming to inspection of the neck, there is no swelling, no scar visualized in the neck. Coming to palpation, the findings of inspection are confirmed on palpation. There is ulcer-indurated lesion 3.5 into X centimeter on the left side dorsum of tongue. On palpation, the posterior border is not palpable. Anteriorly, it is 5 centimeter of the tongue from the tip. Medially, it is crossing the midline to the right side. Laterally, it is reaching to the lateral border of tongue. The floor of mouth is free. On palpation, patient is having severe tenderness. The surface of the lesion is irregular. Edge is everted. Base is indurated. And there is no bleeding on touch. And on the temperature is normal. It is not a warm lesion.
So, Ankit, we'll have some discussion here. Right?
Yes, sir. Yes, sir.
Palpating ulcer proliferative disease with a history of bleeding. How will go ahead? How we will go ahead with this patient? I mean to say on the palpation part.
Sir,
in your OPD.
Sir, for this patient, we had no history of bleeding. But sir, in general, you are asking, sir?
In this patient particular.
Sir, in this patient, she had no history of bleed, and on palpation also there was no bleeding, sir.
Yeah, because any ulcer proliferative growth in base tongue, we should be very, very careful about palpation.
Yes, sir. Yes.
Because if it bleeds, then that lead to bad consequences. So we should be very careful. And better this kind of patient should be. We should do examination under anesthesia, short GA. That is much better way. Please go ahead.
Coming to palpation of the neck, there is no swelling, no nodes palpated. Coming to cranial nerve examination was within normal limit. Systemic examination was within normal limit. Routine nasal endoscopy was done, which was within normal limit. We did a OPD based video laryngoscopy we found on video laryngoscopy, there's an ulcero-indurated lesion on the left side base of tongue, crossing midline. Tongue had restricted mobility. The size of the lesion was 3.5 into 4.5 centimeter. Vallicula was involved. The tonsil, epiglottis, endolarynx, lateral pharyngeal wall, and piriform sinus all were within normal limit. Coming to summary, she's a 71-year-old female with no major co-ops, no habits, presented with dysphagia for 6 months with rapidly progression in 2 months. There is on examination, there is also indurated lesion left side base of tongue extending to vallicula and causing ankyloglossia. So on the basis of history and examination, my provisional diagnosis is a carcinoma base of tongue.
Carcinoma? What do you mean by carcinoma? Without taking a biopsy?
So sorry, a lesion in the neoplasm or a lesion in the base of tongue.
Yeah, it is a much safer way. What does carcinoma means? Like where the tumor can originate?
Sir?
When we say it's carcinoma, where the tumor can originate?
So it should invade the basement membrane, sir. To call it should be
lining epithelium.
Yes, sir. Yes, sir.
So there are different malignant disease which can involve the area, you know.
Yes,
that could be a sarcoma, that could be, you know,
yes,
minor salivary gland tumor.
Correct.
So what I mean to say is that without taking a biopsy, we should not. Yes, we can just a malignant lesion.
Malignant.
Okay.
Sorry, sir.
Yeah.
You can even use the term mass or growth.
Yes, sir.
Of tongue also.
Yes, sir. Yes.
That is even more generalized. So you are not committing to anything.
Yes, sir. Sorry, sir.
But carcinoma certainly is not acceptable at this stage.
Sorry, sir.
Please go ahead. What next?
Sir, we investigated the patient. Sir, our next slide is of the radiological imaging of the patient. Sir, shall I go with the slide before? Should I go to the radiology slide, sir?
So what would you do for this patient after you've done an evaluation? What will you do for this patient? So if you could just tell us about the staging workup for this patient.
Ma'am, I would like to investigate the patient. Till now, I've done an endoscopy and I have a provisional staging on the basis of my clinical examination. And to further confirm the staging, I would like to have a radiological examination. And also to confirm my diagnosis, I would like to take a biopsy of the lesion.
And what more would you do on the biopsy today when you're saying that this lesion is located in the left base of tongue? Is it enough to just say biopsy?
Ma'am, DL-scopy and biopsy.
No. You will do DL-scopy and biopsy, but then when you send this specimen or the matter for material for...
Yes, I would like to do a P16 assay for this patient since it's a base of tongue lesion and the patient is having no habits. I would like to do a P16 assay also to characterize whether it is a HPV positive or HPV negative malignancy.
So what is P16?
P16 is a surrogate marker for HPV, which we...
So how do you ascertain P16 status?
Ma'am, we do a immunohistocytochemistry in the biopsy.
Immunohistochemistry.
Immunohistochemistry, yes, ma'am.
And when do you say it is P16 positive?
Ma'am, usually if it is more than 70% NC ratio, ma'am.
Okay, fine. So more than 70% of the cells that you see are expressing P16.
Yes, ma'am.
Positivity. Okay,
yes,
or uptake rather. Yeah.
Yes, ma'am.
Okay. And what is the concordance? So what is the definitive test for HPV status?
Ma'am, there are multiple tests. Ma'am, PCR, the HPV DNA we can find out, or mRNA expression, ma'am.
Yeah, so the RNA-ish, okay?
Yes, ma'am. RNA-ish is the definitive.
So that is the definitive test for HPV status, all right?
Yes, madam.
So, yeah. So what is the concordance between HPV positivity and P16 status positivity? So today you're using it as a surrogate. So
Surrogate,
definitely it has to have high concordance values, right?
Yes, ma'am.
Others you wouldn't use it. If the false negative rates were high, then this
Yes.
test would not have been used. So it is important for you to know the concordance.
Yes, ma'am. I'm not sure, ma'am, regarding the percentage.
Upwards of 83% in some series, but then it could range anywhere between 70 to 83%. Yeah?
Yes, okay, ma'am.
Yeah. Okay, then go ahead. So you've done a biopsy, you've done a thing, what you call examination and the anesthesia, mapped the disease.
Yes, ma'am.
So next what?
Ma'am, next is, ma'am, before biopsy, I would like to image the patient.
Okay. You want to image before biopsy?
Yes, ma'am.
Is that what everybody does? Because I would be a little...
Ma'am, if we are doing biopsy, then we should wait for some time before taking imaging. It could upstage because of the inflammation. That's why I told.
Are you sure for any kind of biopsy you would want to first do the imaging and then do the biopsy?
If early dates are available, we can do imaging first.
That's being very... No, but what is the normal thing? What do? Do you biopsy when you're doing the DL-scopy, or do you go send for imaging, then ask for a DL-scopy or examination under anesthesia and then biopsy? So what you're saying is true in certain situations, and what is that situation?
What practically we are doing is we'll biopsy on the same day and then ask for imaging. He will get a date for maybe 15-20 days. What practically we are doing is biopsy before imaging, but what I think we should do is imaging before biopsy. I may be wrong.
See, you are not wrong, but at the same time, we really don't do it that way, right?
Yes, ma'am. Yes,
yeah.
Ma'am.
So ideally, either it goes hand in hand. Yes, definitely. If you're suspecting a carcinoma of unknown primary origin, then in that case, with metastatic neck nose, you would try to defer a biopsy before you have a PET-C, CT or something to image or know whether there is any primary anywhere else. But in this situation, often you end up doing a CECT or an MRI and also a biopsy at the same time, right?
Yes, ma'am.
Yeah, okay, fine. So what imaging would you do in this patient?
I would like to do a MRI for this patient, ma'am.
Okay. What is the value of doing an MRI over a CECT?
Ma'am, since soft tissue delineation will be better in a MRI than a CT, ma'am. CT is more useful for bony lesions or cartilage erosion. MRI is better for soft tissue lesions in oropharynx. MRI should be the imaging of choice.
So where will it allow you, give you the advantage, especially what sites in the oropharynx?
Ma'am, depth, ma'am, base of tongue, mainly the infiltration of the extrinsic muscles of tongue, the vallicula involvement, these things, ma'am. Extrinsic muscles of tongue involvement better delineated in MRI than CT, ma'am.
And also involvement of the neurovascular bundle. Today,
neurovascular bundle.
Yes. Yeah. Okay. Fine.
Ankit?
Yes.
Ankit,
yes.
Just completing that topic of biopsy and scan, I think if we are looking at very small lesions, which are, if we do a biopsy, almost the entire lesion will come out. In those cases, if we are doing an imaging, then imaging might be beneficial initially because it might accurately predict the depth of invasion and stuff like that. But in all of the big lesions, which are 4 centimeter in size, your biopsy is not going to change much in terms of edema and staging.
Yes.
So I think in cases you can do simultaneously.
Yes, correct. Yes, sir.
Ankit, would you like to do a biopsy along with the pan endoscopy in these cases, or just do a direct laryngoscopy and take a biopsy and?
Sir,
in simple words, when would you like to do a pan endoscopy?
Sir, pan for neck secondaries with unknown primaries. We should do a pan endoscopy to see some hidden primary, sir. In this case, sir, since we already did a office-based RNA or office-based VLS, now only thing that is left is the bronchus and the esophagus for a pan endoscopy. Other things that are left, I think screening is enough with the RNA and a VLS, sir.
You are happy with DL, but you in the same sitting you don't want.
We can do, sir. Hypopharyngoscope we can use to see the upper esophagus, upper digestive tract.
Why do you want to do pan endoscopy? What do you want to see?
So second primary, because because of field cancerization, there are high chances of second primary in aerodigestive lesions.
Okay.
Head and neck lesion.
So in patients in oropharyngeal cancer, there is a high incidence of synchronous primaries.
Synchronous primaries, sir. Yes.
So we are actually looking for synchronous second primaries.
Yes, sir.
So that you can evaluate by doing a pan endoscopy, or if you are evaluating, and you can include the chest also in the imaging studies.
Yes, sir.
You can do a chest CT also. Even
Yes,
a non-contrast chest CT is good enough to
yes,
pick up the metastasis.
yes, sir. Yes.
Okay.
Do you know what are the types of second primary?
Sir?
What are the types when based on the site and the timing of the second primary?
Yes, sir. So metacrinous and synchronous, less than 6 months or more than 6 months. For synchronous, less than 6 months. Metacrinous, more than 6 months. And also for to differentiate between a recurrence and a second primary, there's a time interval of 3 years, and there should be a interval normal mucosa of more than 2 centimeters.
Do you have specific criteria to call it a second primary versus a recurrence?
Yes, yes, ma'am. This criteria by Slaughter,
the Warren and
Gates
criteria, yes. NCI modification of the Warren and Gates criteria.
Yes, ma'am. They have two things, ma'am. One is the time interval. It should be more than 3 years to call it as a second primary, and there should be it should be not on the same subsite. It should not be on the same site. Minimum 2 centimeter normal mucosa should be present between the other site, and if it is on the same site, it should be more than 3 years. Time period.
And anything about the histology?
Histology can be. Histology, I don't remember.
And what is the field cancerization theory given by? Who is the one who has given the field cancerization?
Slaughter.
Yeah.
Yes.
Okay.
Okay, just one point I'd like to discuss here. So in summary, and in the present illness, you have mentioned ankylosing.
Yes, sir.
So as a surgeon, how would you, what are the things comes in your mind when a patient is having ankylosing?
Sir, if a patient is having ankylosing,
from surgeon's perspective,
so there could be a root of tongue involvement or extrinsic muscles of tongue involvement, sir. Ankylosing signifies these things, sir, for a surgeon's point of view. So
what are the things comes in your mind as a surgeon, like when you are evaluating the patient?
Sir, it will be a gross resection and would require some reconstruction. It will be a deep-seated lesion requiring a gross resection and reconstruction, and there will be chances of there will be chances of leaks, sir. Breach in the floor.
Basically, it signifies advanced disease, am I right?
Yes, sir.
So it's involving the base tongue and even the extrinsic muscle also, perhaps. So it signifies that the disease is in an advanced stage, am I right?
Yes, sir.
Okay.
Ankit, besides MRI of head and neck, would you like to do any other investigation? You want to do any metastatic workup?
So baseline chest X-ray we should take, and this patient is having no notes, but for advanced diseases we should take non-contrast CT as a screening protocol for seeing lung mets.
For chest, non-contrast CT scan.
Non-contrast CT. Yes, sir. Non-contrast is enough.
Okay. So when would you like to do a PET scan in such a patient? Do you have any indications for PET?
Sir, PET scan, if we have lower level nodes, sir, level 4 nodes or bulky nodes, we can go for a PET scan in those cases, sir.
So larger nodes, bulkier nodes particularly in the lower part of the neck.
Yes.
So that per se. Or secondly, in recurrence cases, the patient have already undergone some treatment in the past.
Yes, sir.
Presenting, or there are some other distal symptoms.
Yes, sir. Yes.
So, Ankit, there was a discussion on recurrence of in
Yes, sir.
head and neck cancer. So,
Yes,
can you
sir.
tell me how do you define a recurrence at the same site versus the residual? How do you differentiate?
Sir, recurrence versus residual, the time period is 6 months, sir.
So, if it occurs before 6 months, if the patient has undergone some treatment and the tumor is still there,
yes, sir.
if
we find out the lesion within 6 months, sir, biopsy proven lesion, it will be called as a residual disease. If we find out after 6 months, we can call it as recurrence. That is, then we will not call as recurrence.
So what I understand for the recurrence is that there has to be an interval when no disease, there are no sign of disease in between.
Yes, sir. Disease-free interval should be minimum 6 months.
There has to be a disease-free interval
Yes,
between the end of the treatment,
Yes,
of
sir.
the index treatment,
Yes,
and this particular lesion. So there has to be a disease-free interval. If
Yes,
there is
sir.
no disease-free interval, then it is
It will be a residual disease.
if
Yes,
the
sir.
patient has undergone treatment. Okay.
Yes, sir. Yes, sir. Sir, disease-free interval, if it is less than 6 months, we'll call residual disease. If it is more than 6 months, we'll call it recurrent disease. And if the disease-free interval is more than 3 years and and on the same site, then we can call it as a second primary, not even a recurrence if it is more than 3 years.
Go ahead.
Yes. So next are the radiology slides. So this is we went for a contrast enhanced MRI of the patient, in which we could see hyperintense lesion in the base of tongue, around 4 into 3 centimeter lesion. It's a deep-seated lesion involving the extrinsic muscles of tongue, mainly the genioglossus and geniohyoid. These are the sagittal cuts. On my endoscopy examination, the lingual surface of epiglottis was free, sir. And in this picture also, it looks there's a plane between the epiglottis and the base of tongue, so it looks free, and there are no other. The anterior 2/3 of the tongue and larynx looks free. The lesion is in the base of tongue mainly and the vallicula. The bulk of the disease is in the base of tongue. This is the axial cut of the of the MRI.
Ankit, going on to the sagittal cuts, how do you really on MRI make out which is the base tongue and which is the...
Sir, which is the...
How do you make out what is the anterior tongue and what is base tongue on MRI?
We can, sir, we can see the hard palate, soft palate junction.
Yes, and to where the line going through? You're right.
So I'm not sure.
The junction to the hyoid bone, anything posterior to it will be the base tongue, anything anterior will be the anterior tongue.
Yes.
Yeah.
Okay, sir.
Yeah, go ahead.
Sir, the MRI reporting was there was no bone erosion, no involvement of the tonsil, no involvement of the epiglottis. It was mainly a base of tongue and vallicular lesion. No involvement of soft palate. So on the basis of MRI, since it was a and on my clinical examination, because of ankylosing, it looks like there's extrinsic muscle involvement. So I would like to stage it as a CT4A. And on clinical and imaging, there was no neck nodes. So I would like to keep it as a CT4A and 0 lesions.
Can you go to the axial cut, please?
Sir?
Can you go to the axial cut?
Yes, sir.
Show us the axial cut. Yeah. So, Ankit, just tell us, there are two potential spaces when we see oropharyngeal tumor. We should be concerned about two potential spaces. What are those?
I'm not sure, sir.
Okay, so you have to see retropharyngeal space. Okay?
Yes, sir. Yes, sir. Retropharyngeal. We should see for retropharyngeal space any retropharyngeal lymphadenopathy in the MRI.
Right. And another is peripharyngeal space,
Yes,
because
sir.
any extension of the disease to peripharynx, that is a very important point. We really need to see the peripharyngeal space, whether there is any disease advanced or it has spread to the space. Okay.
Yes, sir. Yes, sir.
Okay. Go ahead.
We we took a biopsy of the patient. The biopsy report was moderate to well differentiated squamous cell carcinoma. We did not do a P16 assay at our so biopsy was moderate.
What do you think it would be? P16 positive, P16 negative?
Ma'am, I think it is P16 negative only, ma'am.
Okay. Why?
Ma'am, since the primary is big, ma'am, and there are no neck nodes, ma'am. Usually, the HPV positive lesions should have large cystic nodes with a small primary. These are the favor against HPV positivity in this case. The only favor against HPV positivity, but the only favor for HPV positivity could be no. She's a female with no habits, but other clinical examination and all shows that it could be HPV negative tumor.
Ankit, what are the subside of oropharynx?
Sir, subsides of there are 4 subsides, sir. Base of tongue, tonsil, soft palate, and posterior pharyngeal also.
So, which subside is mostly involved in HPV positive group?
Sir, base of tongue.
It's tonsil.
Tonsils.
Palatine tonsil.
Palatine tonsil. Sorry, sir. Base of tongue in HPV negative. Palatine tonsil in HPV positive.
Why?
So there's deep-seated crypts in which the viral can enter and invade, sir. Microtrauma in the deep-seated crypts of the tonsil, sir.
And basically, because they can be chronically treated there, and
yes, sir.
immune the body doesn't act against them, so the
yes,
immune cells don't work, and yeah. You know the mechanism of HPV causing cancers?
Yes, sir. Little bit.
Yeah, just tell me. Basic, at least the 4 main names, E and P.
Sir, this first there is a microtrauma and a long-seated infection that will cause this E6 and E7 protein will cause some changes in the P53 and RB gene, sir. P53 is not mutated, but it becomes dysfunctional. So that's a tumor suppressor gene.
Yeah.
Mainly, it should be a long-standing infection.
Yeah, go ahead.
So that's end my slide, sir.
Okay.
How much percentage in India are HPV positive oropharyngeal cancers vis-a-vis Western population?
Sir, in India, around in oropharynx, around 30%, sir.
That's a very high proportion you're saying. Maximum is 22%. It's almost to the tune of 15 to 22% from various series. It's not more than that. So what's the difference in our HPV positive population, or rather our oropharyngeal cancers, compared to the West? So you said it was the palatine tonsil that was most commonly involved in the West. What
yes.
about us? What do we see here more commonly?
I'm not sure, ma'am. Maybe base of tongue.
That's correct, because and that's again another reason why we are not going to be able to use TORS so much,
yes,
because of the kind of oropharyngeal tumors that we see, right?
Yes,
one is larger tumors, base of tongue tumors.
Yes,
so you have to know what is the difference in our oropharynx population vis-a-vis the West. One
yes,
is the HPV status, but the other is also the location, the lymph node involvement, and the association with tobacco.
Yes, ma'am.
So HPV positive patients, they're typically younger patients. They don't have any, and the exposure to tobacco and smoking is very less or not at all. And they'll be younger with smaller primaries and bulkier secondary lymph nodes.
Yes.
And what is the incidence in the West?
Sir, it is increasing. I'm not sure it's around. I'm not sure the percentage, sir.
More than 80%
More
in
than
the
80.
West are HPV positive.
Positive.
And in several countries, almost all the newly diagnosed oropharyngeal cancers are HPV positive. So it is an epidemic over there.
Yes, sir.
HPV epidemic.
Yes. Yes, sir.
Yeah, please proceed.
Yeah, Ankit, one more thing.
Yes, sir.
When you have summarized this patient, what is the best prognostic part in your patient?
Sir, one is that she has no habits, sir.
Okay. And what else clinically?
Clinically, sir, her performance status is good, sir.
More than that?
Yes.
No
more than
notes,
that.
no notes, sir.
Yes, no notes. Once in head and neck, there is clinically positive node. Survival goes down by what percent?
50%, 50%.
Yeah. So, as because she's clinically node negative patient,
Yes, sir.
so obviously she has a better prognosis. Okay.
Yes, sir.
I think you should, when somebody asks you this question, you should talk about patient factor and tumor factor and then elaborate both properly.
Yes, sir.
Look, what do you think for TOS? If you consider TOS, what are the indications of TOS? What are the contraindications of TOS?
Sir, for this patient or sir in general?
General.
Sir, general TOS can be done in in early stage lesions, sir, for T1, T2, and also some selected T3 and T4A. But in base of tongue, if it is in this for this patient, sir, since if it is crossing midline, bulky base of tongue lesion, there will be a concern regarding doing a TOS, sir. Injury. Yes, sir.
What are the contraindications? Okay, I'll make it easier.
Sir, contraindications is lateral extent to the parapharyngeal, sir. Deep-seated tonsillar lesion with parapharyngeal extent, prevertebral fascia extent, bone involvement, and also, sir, T4A lesions with bone involvement, and sir, parapharyngeal extent, prevertebral fascia extent, or sir, if there is a non-T, if it is a retropharyngeal internal carotid artery on in a tonsillar lesion, then also it's a contraindication for TOS. For bulky base of tongue lesions, when a resection would compromise both lingual arteries and hypoglossal nerves, then also it's a contraindication for TOS.
Okay, so I think again you should, whenever you answer, I think the only thing is you need to divide them so that there are three factors. One is vascular factor, patient factor, human. So when you talk about vascular factor, it is the the pathway of the carotid artery if it is coming in during the surgery. Second is if bilateral lingual artery needs ligation while tumor crossing midlines.
Yes, sir.
Then the patient factor, you have to understand that even mouth opening trismus plays an role in this case. So if and the patient condition as well. So whether it's old age, surgically with multiple comorbidities, the aspiration after the surgery is going to be higher. So you have to take those patient factor into consideration. And then what you're talking about, the tumor factor is basically the extension, bone involvement, retropharyngeal extent, and all those things. So what are the other factors which, if you're not supposedly not planning a TOS, what are the other surgical approaches you can consider in an oropharyngeal cancer?
Sir, external approaches like mandibulotomy or mandibulotomy for access to the base of tongue or tonsil. Other is a transhyoid pharyngotomy. Or if there's bone involvement, then a lateral mandibulectomy. Lateral segment.
So what are the types of mandibulotomy and what are the advantages and disadvantages of each?
So there are three types: median, paramedian, and lateral mandibulotomy.
Yeah.
So the disadvantage of a median mandibulotomy is that the attachment of the muscles to the genian tubercle is lost, so there can be tongue fallback in a median mandibulotomy.
What is the advantage?
Sir, advantage is that
so it's not in the radiation field, the probability of over.
Yes, sir. It's not a radiation field, sir. And in a lateral mandibulotomy, the problem is injury to the mental nerve. and also it's the radiation field. So best among both is the paramedian mandibulotomy, in which the genial tubercles can be saved. We can go between the incisor and between the lateral incisor and the canine. We can save the mental nerve, and both the disadvantages of the lateral and the median mandibulotomy are avoided in a paramedian mandibulotomy.
So what happens at paramedian? Why that site particularly?
Sir, among all three, I think the best is paramedian. We can avoid injury.
Site.
The reason.
Is there anything about the root of the teeth?
Yes, sir. Both are widened, sir. The lateral incisor and the canine both are. We can easily go in between, preserving the both teeth.
So they actually have got, Ankit, divergent roots.
Yes, sir. Divergent roots, sir.
Divergent roots, and you can safely make a cut in between without injuring any of the tooth or without removing any of the tooth.
Yes.
But is there any contraindication of doing paramedian mandibulotomy? Any contraindication? Do you understand?
Yes, sir.
Are you getting me?
Sir, I'm trying to think for an answer.
Oh,
Sir,
okay.
I'm not sure.
Suppose in severe trismus, would you like to go and do a mandibulotomy? Or if it is a edentulous post-mortem mandible?
Yes, then we'll avoid.
Yeah. Okay.
And previous radiation, it's not an absolute contraindication.
Absolute contraindication.
There is a poor
yes, sir.
outcome.
Yes.
Just Ankit, I wish to add one more contraindication to transoral robotic we were discussing.
Yes, sir.
That you must be able to expose the tumor in your DL evaluation completely. Yes. You should be able to see all the margins and the surrounding healthy margin which you want to resect.
Yes,
if you
sir.
If you cannot see the tumor preoperatively, you won't be able to resect.
Yes, sir.
So these patients should have an adequate length of the neck. They should not be short neck patients, and they should not have received previous radiation to the neck. So which makes it more difficult to extend here. So these are the two contraindications as far as the TORS is concerned.
Yes, sir.
With regards to TORS, have you read the Orator trial properly? Like, which subsite in oropharynx with regards to TORS has poor outcome? I'm talking about tonsil versus base tongue.
So base of tongue.
So what was the outcome in Orator in terms of base tongue resections?
Sir, a more number of more tube dependence, sir, more tracheostomies.
No, okay. So I think what was important is Dr. Sarbani has rightly mentioned that there was no meaningful clinical difference between the two arms. But I think in the subset analysis, they did two subset analysis. One is for the base tongue cancers, and one is those who required adjuvant radiotherapy after TORS. In these two sets, they found that there was a meaningful clinically difference in the Madari scores for swallowing. So base tongue did poor in swallowing, and those with required adjuvant radiotherapy did poor.
Yes, sir.
So what is the question is, how many percentage of patient after TORS requires radiotherapy on an average?
So that depends on the stage of the lesion, sir, initial stage.
Yeah, but on an average, the literature, what does it say? How many patients?
So that I'm not sure, sir.
You can make a guess, because how many patients will have a neck node, on an average? Early oropharyngeal cancers. So it's around 40 to 50% by. And what about the PEG dependence? How many patients do all the Weinstein series and all? How many patients did require a PEG in post-TORS cases? So it was 0 to 7%.
Yes.
Okay. So yeah. And what are the other surgical modalities you can consider if you don't have TORS and you don't want to do an open? What are the things you can consider?
So we can do a transoral laser surgery.
Yes. So what are the benefits of TORS versus transoral laser surgery?
So transoral laser surgery, sir. we can use that same retractor system to take out the lesion, but the laser can we can do re-excision at the same size. If the frozen is positive, the laser can burn the margins and coagulate it. So like in microlenses, so the margin issue will be less since we can re-excise in the same sitting.
No.
It's sir, it coagulates the margins, so that only advantage of laser over cold instrumentation, which I could feel.
Even with TORS, you will coagulate the margin with.
So then,
so what are the of TORS basically and disadvantage of TORS? If you remember that, you can correlate well.
Sir, sorry, sir.
What are the advantages of TORS?
Sir, TORS advantage is that sir, exposure and that endo-wrist movement, sir, it gives us more degree of degree of freedom in movement, sir, and then good exposure. There's a console 3D visualization in a console, sir, and also since the robotic arms can go inside, there's a manual assistant, so that forehand surgery, which is not possible in conventional things, can be done with a robot, sir.
And magnification.
And
what are the problems with laser surgery?
So laser, we won't have those robotic arms and that degree of freedom, sir.
So what is the problem? Yeah, you're right.
So exposure and that we won't have a manual assistant like we can have in.
I mean, so the problem with it has to be very linear, right? Your exposure has to be
very good.
Can't going in.
Yes.
And but TORS, you get the 360-degree freedom, and you can do. So which place normally laser surgery is happening in the world? Then TORS, like they prefer laser surgery more.
Yes, sir.
Which is the place? So in Europe, I think Europe laser surgeries are more common as compared to TORS. And who is the guy who has published more about laser surgeries for oropharynx? Is Steiner.
Okay.
Yeah.
Just wish to add, Ankit, there's another option by Taus. Taus is also available for Oropharyngeal lesions.
Yes, sir.
It's time now. Ankit, just tell me, how would you like to go ahead with this patient? What kind of treatment modality you want to choose for your patient?
Sir, I would like to go for a non-surgical management, sir, concurrent chemoradiation for this patient, sir.
Okay. Good.
Organ preservation, concurrent chemoradiation.
I think it's time. I think we should conclude here.
Ankit,
yes,
time up, I can ask, or Ravi, is it time up? Ravi?
Yeah, hi, Dr. Manish. Thank you so much.
Or is it time up?
Yeah. I think we can conclude. I would like to have some concluding remarks from all the examiners about how did Ankit perform and any input that you would like to give to how to improve, how to move ahead for his exams. I think Sarvani ma'am has left. Ashok sir?
Yeah, Ankit, at your level, we would like to see how much confident you are clinically, you see, rather than sophistications, what information you can get from the patient, presenting symptom and your clinical examination.
Yes.
We would like to see your, confidence in that. And now you might have seen from the presentation of Sarvani ma'am that things are changing rapidly. So we need to be updated on the recent changes in the management and the whole scenario of this thing.
Yes.
Okay, good.
Yes.
Otherwise, you have presented well.
Thank you, sir.
Anything from Dr. Vipin or Dr. Manish?
Yeah. Ankit, you presented well.
Thank you, sir.
And your everything was facilitated by Dr. Sarvani's talk earlier, so she could summarize everything well. So we don't have much to ask about the radiation and medical oncology.
Yes,
she
sir.
summarized it so well.
Yes.
And Thirdly, it is primarily a topic of radiation oncology.
Yes, sir.
But you should be very thorough with the landmark trials. Landmark trials, particularly on de-escalation,
Yes, sir.
de-escalate HPV, and
Yes, sir.
other trials, orator trials. You should be very thorough with that what is the outcome
Yes,
in these particular trials and what was actually achieved, because de-escalation is a very hot topic.
Yes, sir.
Another thing I would like to add is Dr. Sarbani is advocating escalation in oropharyngeal cancers in India. So
Yes,
that is something that gives us a food for thought, and we must consider that, because most of the cancers in oropharynx we are dealing with are HPV negative cancers.
Negative.
So
Yes,
you
sir.
presented well. Congratulations to you.
Thank you. Thank you, sir.
So, I think we can call up the meet now. Thank you, everyone. Next class is after 2 weeks on Thursday, same timing, 5:30 to 7 p.m. The topic will be oral malignancies. Hope to see you in that meet too. Thank you, everyone.
Thank you very much.
Thank you.